Recording in progress.
Hi, can I check my share screen?
Yes, sir. No.
Can you see?
Yes, ma'am.
Okay, I'll just run one of the videos and check. Okay.
Yes, ma'am. It is working.
No, video I'll run. This one I have to run. Let's see.
Okay.
Yeah, it's running well. Okay, fine. I'll do the stop share.
Yes, ma'am. It is
Okay.
running. Video also.
See, I also have lots of videos, so I don't know. Recording is not very palatable because lots of patients video and we haven't taken consent, for all.
Okay.
Maybe I can send you later on without the videos, all the slides.
Okay, so I stop the recording. Yeah.
Hello?
Yes, yes.
I can't hear. No, I said because there are lots of patient videos, it's
Okay.
difficult to record this. Yeah, better not to record. We haven't even taken consent for all the patients.
Okay.
Maybe
Okay.
there are few patients who are just added since last 2 days. We haven't taken any consent.
Okay.
Yeah.
Hi.
Hi. Today I'm before time because I have to present.
Slides check कर लिया संगीता संगीता
Yeah.
Hello, did you check your slides?
Yeah.
Okay,
I did.
chalo.
Yes.
So we can mute and put off our video and we'll join again at 2 minutes to 7 or sharp 7.
चलेगा. Yeah.
मैं थोड़ा I'll just finish drinking some water and come from downstairs. Okay, all the best, huh?
Okay.
Bye.
Yeah.
Bye.
I'm going to go for an hour as it looks like.
हाँ 1 घंटा आराम से करो. हाँ, no need to
Okay.
rush through. Only thing is
Yeah.
sometimes they ask questions. They ask if there are too many questions, then maybe I will let you know. If there are hardly
Yeah.
any questions, then you can आराम से go for. हाँ.
Okay. ठीक है. No, मैंने 2 केस एंड में रखे हैं, तो if there is time I'll show the case. Otherwise I won't show.
Yeah.
Those
You know
just
नहीं cases.
operated
सुनो.
case.
हाँ, cases
नहीं
are
नहीं
also
वीडियोस में
important
पहले
because.
दिखा रही हूँ, but the last 2
हाँ,
केस
फिर
I'm
ठीक है,
showing
फिर
that.
not. हाँ.
हाँ, आगे का वीडियो
अगर
सब
टाइम है.
है. हाँ, last 2
हाँ.
frustration, okay, कैसे होता है, that 2 case I just wanted to
ठीक
show.
है, ठीक है, ठीक है, ठीक. ओके, ओके, बाय.
Question,
जयपुर तो आएगी
questions
ना
तो
इकॉन
मंजरी can
जयपुर.
always answer.
हाँ, इकॉन तो जयपुर में आएगी ना इकॉन. तो तुम्हारा
आएगी.
फ्रंटल लोब. हाँ, फ्रंटल लोब
Yeah.
एपिलेप्सी टॉक डाल दूं क्या सेम ही डालूं या और कुछ दूं बताओ. सीएमई में उन्होंने रखा है ना.
हाँ, डाल दे चले. हाँ, डाल
ठीक
दे,
है ना.
डाल दे.
तो मतलब ज्यादा तुम्हारे ऊपर स्ट्रेन भी नहीं पड़ेगा बिकॉज यू आर ऑल्सो बिजी.
या
तो
एब्सोल्युटली बहुत हार्ड प्रेस टाइम के लिए. ओके. या
ठीक है, डन. ओके, ओके,
ओके.
बाय.
बाय.
Okay.
Hi.
Hi. More people will join, so we'll start off. 3 minute है अभी. Usually last minute तक join. By 7:20 there are around 250
250 हो जाते हैं बराबर देखा मैंने.
हाँ. पता नहीं, should we change the timing because by 7:20 only there are more number of people. 7 बजे fewer join. I don't know why.
Someone had written last time the answer that when you are asking, no, it's because of the time zone difference. ऐसा किसी ने लिखा था.
अच्छा maybe. हाँ. बाहर के भी लोग हैं ना इससे.
हाँ. बाहर के काफी लग रहे हैं मेरे को.
हाँ. From many countries, even UK, US, बहुत सारे countries से join कर रहे हैं.
अच्छा. So we are internationally.
अपने स्टूडेंट्स को मेंबरशिप बोलो ना कि हो जाए.
हाँ, मेरे जो पास हुए सब हो गए.
अच्छा. बिना पास हुए भी हो सकते हैं. ऑल यू नीड इज टू बी एमबीबीएस.
अभी बस एक लास्ट का 2 था, उनको बोला है मैंने.
हाँ.
बिना
उससे
पास
फिर
हुए
ना एक्चुअली
अच्छा
क्या होता है ना, मेंबरशिप नेक्स्ट जीबी या नेक्स्ट मिड टर्म में मिलती है. तो जब भी अप्लाई करते हैं इट विल टेक 6 months टू गेट द मेंबरशिप. तो वो पहले से करेंगे तो अच्छा है, नहीं तो फिर वो जस्ट कॉन्फ्रेंस के पहले करते हैं. कॉन्फ्रेंस के पहले
थर्ड ईयर वाले को सबको बोल देती हूँ. थर्ड ईयर वाले को बोल देती हूँ.
So if they can apply at least 6 months before the conference, then we can midterm में उनको, जैसे अभी बहुतों को हमने membership दिलवाई in the midterm meeting in Jaipur. So उसके ना फिर in the conference they are able to present them and they get reduced registration rate also.
मैं बोल देता हूँ. मेरा गला थोड़ा खराब है.
हाँ, वायरल बहुत है. आई एम स्टिल रिकवरिंग. मेरे को अभी भी खांसी है. लास्ट वीक लाइक मिड टर्म मीटिंग के लिए मैं गई, बट आई कुड नॉट गो डाउन. आई वाज प्रेजेंटिंग फ्रॉम माय रूम. I was down with a bad blocked nose and cough and bad sore throat. अब जाऊंगी नीचे तो सब लोग इन्फेक्ट होंगे.
रिकवर हुई, बट अभी भी गला थोड़ा ऐसा ही है. बीच बीच में ऐसा खाना पड़ता है. एक खाती हूँ.
7 o'clock हो गया. Shall we start? We'll start.
Yeah.
We'll start. 100 people have joined, which is a good number.
Yes.
Mr. Mohit, we are starting. Is the recording on?
Yes, ma'am, it is on.
Thank you. A very good evening to all of you who have joined us for this session of the Indian Epilepsy Society EEG workshop, which we are holding every Wednesday from 7 p.m. onwards. Today we have an iconic figure, which is Dr. Sangeeta Rawat. She is a great epileptologist from Mumbai. And, she runs the comprehensive epilepsy care program there in the KEM hospital. But she's also the dean of KEM hospital. And indeed, it's a proud privilege to have her here. And she will talk about, frontal lobe epilepsies. Dr. Sangeeta?
Yeah. Good evening. I'm also the co-host with Manjari, but she has done all the hard work. So today we are going to talk on the frontal lobe epilepsy. And in next, I think almost for an hour, I'll be talking to you on the frontal lobe epilepsy. So we all know, frontal lobe epilepsy itself is a challenging part. I'll be covering the features, that is the of the frontal lobe epilepsy. What is so special about it? The auras of frontal lobe, the semiologies in frontal lobe, and the Bonini's new grouping, which is a bit difficult and not is followed by many, but I'll just try and show you what that is showing. And then finally we go to the ictal and interictal EEG during the frontal lobe epilepsy. Now, frontal lobe epilepsy is always difficult to treat. And why is that? It all constitutes almost 20 to 30% of the focal epilepsies But in a surgical series, if you go, the majority are temporal. Only 20% may be a frontal lobe epilepsy. Interictal, and whenever the patient comes to a routine neurologist, apart from our epileptologist, usually an interictal EEG is done for frontal lobe epilepsy. And most of the time it turns out to be normal. 40% do not show any abnormality. So it becomes challenging to diagnose the frontal lobe epilepsy because the semiologies are very short, bizarre at times. So why is that? So let's go over to some of the basic parts. Now, basically, frontal lobe, is the biggest part of the brain lobe. It's an uncharted province. 1/3 of the total hemispheric volume is by that, and it has got extensive connections. And then because of that, there is a rapid spread of the ictal activity in the various directions. Second most common drug-resistant epilepsy syndrome. And it has a very, you may have just a clonic seizure of one hand, you may have a bizarre phenomenon of complex automatism, stereotypies, and which may be misunderstood as a psychogenic attacks. So that's why it is difficult to understand these seizures, and that's as we don't understand them well, it is also difficult to treat this frontal lobe epilepsy with drugs. So just to revise the basic anatomy, you all know that this is a lateral aspect, dorsolateral aspect, where this is the prefrontal area. The green is the limbic area here. This is the premotor area, and this is the motor area. And we have an inferior orbital aspect, and this is our medial aspect. Okay, so these are the basic anatomical things which before when we are trying to classify the seizures into from which lobe they are coming. Now, what are the challenges? First is often unclear relationship between the semiologic pattern and the sublobe curve, whether it is coming from dorsolateral, whether it's coming from mesial, whether it's coming from lateral, and then it's difficult. Secondly, it is often nocturnal, and so that's why we do not see any obvious EEG correlation. And that's why it is often misdiagnosed as parasomnias. It represents the 35 to 40% of the total cortical volume, the frontal lobe. And accurate delineation is challenged because it's a large surface, but there is also a big buried surface on the medial aspect, on the ventromedial aspect. So the scalp EEGs do not reach till there. And that's why we do not pick up those abnormal discharges from the deep within. And that's why it becomes more and more difficult to localize and lateralize. So let's go over to what are the basic features of frontal lobe seizure. So I'll be covering the semiologies first, and then we'll go to the EEGs. Basically, it's a very short seizures, unlike the temporal where it is almost for a minute to 1.5 minutes. This is few seconds, and usually it comes in clusters. And the nocturnal clusters are very typical of it. There is a sudden onset, sudden offset, and patient hardly has any post-ictal confusion. Early motor signs, frequent vocalization is there, tonic posturing is quite often. And then there is a typical bimanual, bipedal automatism, hypermotor seizures, and no post-ictal confusion or very little post-ictal confusion. Now, why is semiology so important in frontal lobe epilepsy? Because there are certain reasons for it. First of all, scalp EEG, as I said, has a low sensitivity and specificity for frontal lobe epilepsy because the mesial and basal frontal are inaccessible to the standard 10-20 system. If you are using a depth stereo EEG, definitely it becomes better. Almost 25 to 45% frontal lobe epilepsies have normal MRI. And that too after doing 3 Tesla with a good epileptologist, it still can be normal. PET positivity in those who have abnormal MRI is good, 75%. But those who have normal MRI, PET positivity is also in 30 to 40%. Now, these are very short-lasting seizures. So, ictal SPECT is also where it becomes difficult because by the time you inject, it becomes generalized. So, even ictal SPECT is limited value. So, important thing is semiology will guide you further investigation where and how you should go further. So now let's go over to the auras. So when you go over to the aura, there are two, papers which I have cited here. Both have studied frontal and temporal lobe. Let's go to the frontal lobe. One has studied 52 seizures, another has 53 seizures. So somatosensory auras are one of the commonest. ranging from 12 the one study says has a 35%, other is saying 12.5%. Then some may have a psychic aura. And then fear is one of the common thing which you find. Almost 19% patients may have fear. And there are others, general body sensation, olfactory, which are not very common with frontal lobe seizures. So now there was a landmark paper in 2016 by Hans Luders, and he analyzed the 47 seizures by 3 neurologists independently. And he defined certain terminologies and what is the localization value of that. So the first is a tonic, a sustained contraction of one or more muscle group, duration more than 3 seconds. It may affect one or more limb or face. And unilateral tonic activity like this has a lateralizing value to contralateral hemisphere of approximately 90%. Second is clonic, a rhythmic clonic movement at the interval of 0.2 to 5 per second, affects usually the distal part of the extremity or a face. And this also has a contralateral hemispheric localizing value of almost 90%. Version, a forced, sustained, unnatural head and eye version with the chin looking up. Now, this extension of neck muscle leading to chin upward occurs within 10 seconds before the motor generalization has a high lateralizing value to contralateral hemisphere of more than 90%. Fourth is a figure of 4 sign, asymmetric tonic posturing, defined as tonic posturing, extension of one arm with the contralateral arm bent tonically at either in front or behind the tonic arm. It occurs at the beginning of the tonic phase of the GTC, and again it extended arm to opposite side, contralateral hemisphere in 92% of cases. Asymmetric clonic ending, when at the end of the GTC you see that one side, right side supposing is contracting, the last 2 jerks are coming from that side, then it's the ipsilateral hemisphere, the right hemisphere is probably the lateralization. That's 83%. Torts paralysis, almost 100%. We all know what is tort paralysis, one side body having a paralysis, and that localizing value is almost to the contralateral hemisphere, almost 100%. Dystonia, again coming from the basal ganglia by spreading over there. It also has a good localizing value, but the percentages in this paper was not very clear. Then comes the M to E, mirror to eye sign, described way back by Marcel in 1957. A tonic movement, elevation of one arm, flexion at the elbow to 90 degree, followed by an abduction of the shoulder, approximately to 90 degree, associated with external rotation, and the head turned towards it as if you are looking at the mirror. Now, this has a very strong lateralizing value pointing to the contralateral hemisphere. And the opposite arm should be relaxed during that time. So now let's come over to this paper where the seizure semiology and pre-surgical evaluation very well described in different in the frontal lobe. So the areas defined are the frontal eye field, dorsolateral prefrontal cortex, and then the premotor areas, and then the precentral primary motor area, frontal operculum, and etc. So let's go to the frontal eye field. Version of gaze and eye deviation to opposite side. Now this gentleman who came from Singapore, he was an engineer, had frequent these seizures. So you can see the head and eye, which he has an aura, so he immediately puts this thing in the mouth to prevent a tongue bite. Head and eye deviated to the left. And then he goes into a generalized seizure. Okay, so we won't go further into this. He had a good cysticercus scar here on the right side. PET is also showing the same. And the EEG also showing in the right side. Discharges in the interictal area. So he was operated almost, I think now 15 years back, and I have no clue because he's not come for follow-up after first 10 years when he was free. So let's go to the second part, dorsolateral, which is a big part of the brain. Here it's you may have a complex automatism, semi-purposeful movement, frontal abscesses, various things are described. So this young girl as comes with this very typical proximal movements. You can see the flexion extension of the, and all her seizures are stereotyped. It is very important when you want to differentiate it from the pseudo seizures, that frontal lobe seizures, they should be stereotyped. Whereas in any AD, you may have a different. So here there is some confusion. Probably it's maybe going to the temporal. So that was a complex automatism which you saw. Now let's go to the third area, that is premotor area, including that's an SMA where you'll have an asymmetric tonic posturing. So in this girl, you can see the right hand goes into tonic posturing, right leg goes into tonic posturing, head and eye deviates to the left side. And then she goes into a generalized seizure later. So she had this left frontal dysplasia, which is also showing into the increased perfusion in ictal spect, and the EEG was also localizing. But we haven't operated her because it was a left frontal near the language area, and she was well controlled with the medications. Then we come to this ventromesial. Here you have a limbic system also, so you have the emotions involved here. You also have a hyperkinetic motor behavior here in the seizures arising from this area. So we'll see the example of both. This is the young boy who has this seizure. You can see the rolling, and you can also see that there is a little fear on the way he shouts. He is scared, and he has this hypermotor seizure. There is also, now you can see he's answering, but he keeps saying pratik, pratik, pratik. So there is a bit of perseveration. And this was his MRI showing the dysplasia in the right front anterior insular region. Now, another girl. This is also, she gets up and she again has an hypermotor behavior. And then you can see how scared she is. She has fear, she has hypermotor. So this frontal lobe seizures, though they are short, but they are really, devastating to the patient, and very difficult to control the patient during this. See, she's scared even with the pen. So you can understand the fear is very obvious with the hypermotor seizure. She had this left intertemporal cortex, a medial region, a dysplasia. Now let's go to the other group, which Bonini and they studied 54 patients with stereo EEG, and total of 374 seizures were studied. And they have defined some semiologic features with concomitant EEG changes, and they divided them into 4 groups with semiologic features which are correlating anatomically into that seizure localization. So some semiologic features we need to understand what they have used. First is the elementary motor signs. So the tonic-clonic movement, dystonic posturing, head and eye version, these were considered as elementary motor signs. Second part is the gestural motor behavior, that is complex motor behaviors. In this, they divided integrated versus non-integrated. I'll come to it later. Third group was the stereotypies, in which either they have a repetitive similar action, and it may be either a proximal stereotypy or a distal stereotypy. And the fourth was a hypokinetic movements, where consist of excessive amount of movements and or excessive amplitude, speed and acceleration that appear violent and inappropriate to the situation. So these were 4 major semiologic features which they defined. And the integrated versus non-integrated. Integrated is like a naturalistic pattern, as if you are going to reach to someone, you are trying to grasp something, you are paddling, you're kicking. So it's like ordered sequence of movement within the seizure. You are rocking, you are hitting. And also there is a facial expression with this, which is a normal type of facial expression. So you may have a happy facial expression like singing, laughing, smiling. Non-integrated is disjointed or even anarchic appearance, including the facial expression of disgust or things like that, which is non-integrated movements and abnormal facial experience. So with this, they're divided into the 4 major groups. Group 1 had elementary motor signs, and it involved the precentral and premotor. So it's a proximal one. There you'll have a elementary motor signs, because the motor cortex is nearby, so you'll have that. Then second group, as you go in the anteriorly, it's combination of elementary motor signs plus non-integrated gestural motor behavior. This comes again premotor and the prefrontal regions. Third group is integrated gestural motor with like distal stereotypies. And here it's anterior, lateral, and the medial prefrontal region. Okay? And the fourth group is seizures with fearful behavior. Here it is a ventromedial, paralimbic cortex, and anterior temporal structures. So now let's see whether we see the examples of each of them. So the group 1. So it will have one or more elementary motor signs, clonic signs, contralateral tonic posturing, contralateral versive sign, asymmetric tonic posturing, asymmetric facial contraction, and it will not have an abnormal gestural motor behavior or emotional component to it. So the area is Rolandic B4 area, Rolandic operculum. You can see here area 4 and the parietal area and the SM. So these are the area. You may have a somesthetic localized aura. So let's see the example of that. Now this girl, she lies down, and then there is a tonic posturing of the left hand, and the right hand is also going into the flexion. Her MRI was normal, but we did the ictal SWAG, and that showed a right superior frontal lobe and ictal focus. So her seizures were pretty short lasting. Second group comes elementary motor signs, typically asymmetric, axial tonic posture, facial contraction. Here they describe the chapeau de Ganderme. Here I will show you some of, and the non-integrated gestural behavior like proximal stereotypies, non-localized auras, and frequent involvement of the premotor. Now here you can see the premotor area 6, insula, and the area 9, lateral prefrontal region. These were the one. And ictal discharge may show from the medial and lateral aspect both. You may not be able to localize the ictal discharge from one area. So chapeau de gendarme refers to a shape of the gendarme's hat which was seen in the Napoleon First. It's a symmetrical, sustained lowering of the labial commissures with contraction of the chin, mimicking an expression of fear, disgust, or menace. Early symptom which occurs as the first symptom within first 10 seconds. It may be associated with psychic aura, with fear or anguish, followed by a behavioral disorder, agitation, fighting. It has a high seizure frequency. Whenever you have a chapeau de as one of the presentation, most of the time the seizure frequency is high and it may occur in clusters. PET may show either enter commissure, enter insula, or a cingulate gyrus. Now this lady, you can see the facial grimacing, though, she's covering, but is the facial grimace, I think, quite obvious. Here you can see that quite obvious chapeau she has, and she has this lateral dysplasia. This area is pretty common for dysplasia. But important thing is in this, the EEG might be showing a bilateral thing. So it is important that you even if you are seeing here bilaterally, you have to go with this and remember the, that if there is a chapeau and if you are seeing this, you can definitely say this is arising from the left parafalcine region. Another example of chapeau. He has this on the left side, the dysplasia. And you can see that he has a face turning, a shape which is occurring. The left hand has some automatic movement. Right hand is going into dystonia. Probably it's going into the temporal area from here. See, the seizure is over and is already answering the questions. Okay. So then comes another part is the actual position. Some stereotypic behavior. This was also told as a pranzel boy, where you know the pranzel, a sweet which comes to eat. It has this type of round, it's like this. You can see these typical movements. Unfortunately, I don't have the MRI of this. So he is. So such type of proximal stereotypy movements can also be there. Then come the group 3. Here you have an integrated gestural motor behavior with distal stereotypies, fixed facial expression, or you may also have the proximal stereotypy with speech production, but absence of any elementary motor signs, like tonic posturing and things like that. Here again, it's a rostral ventromedial aspect of the region plus cingulate gyrus, here cingulate gyrus and the rostral ventromedial area. These are the area from where they picked up the maximum this thing. So let's see one example of that. This girl, she gets up. Probably she had an aura. Now the mother realized that she's having a seizure. You can see that she has both hands, both legs, and fear. She has this gyrus rectus FCD. She's already conscious and she's obeying the commands. She's answering that this is pen. She answers correctly. Then come the group 4. Here you have a fear, which is sometimes you may have a hyperkinetic or you have frightened facial expression here, and it's this occurs in the orbital, prefrontal, and again medial prefrontal network. It may be propagating to amygdala and anterior temporal regions, but not to the lateral frontal cortex. And allometric motor signs never occurred in this area. So this girl, you can see how scared she is with fear. She had a right middle frontal gyrus FCD. That's all her seizures are, so short lasting. Then comes hand posturing. Now this almost 72% of the frontal seizures have this tonic hand posturing. Fist and pointing feature predict the frontal lobe localization, but not lateralizing. So this fist and cup and this are more of a temporal lobe. But if you see this pointing finger, extended hand, it is more likely to be a frontal lobe. You can see this girl. You can see this finger pointing here, head and eye version to the left. And now she has a right hand going into the posturing and the right leg posturing. And then she further goes into secondary analyzation. Unfortunately, her MRI didn't show us anything. Maybe she requires a stereo EEG for further localization, which So now we go over to, these are, I've shown you the various types of semiologies. Now let's go to the interictal EEGs. So the interictal EEG, let's go to the first is the mesial frontal seizures. The mesial frontal, you know, it is in the depth, remote from the recording electrodes, and poor orientation. It's a tangential orientation of the seizure onset zone. And it is complicated by artifact because it has a prominent motor features. So the scalp EEG doesn't help so much. You may see rhythmic midline parasagittal theta or delta activity. You may, even if it is a one-sided lesion, you may see bilateral frontal synchronous discharges. But these are not specific for it, but you often see that when there is a mesial frontal midline, this thing. Now this one, you can see that there are synchronous discharges, but also there are some where it is more on the right side. So these bilateral frontal synchronous discharges, but preponderance is definitely there in some of the areas on the right side. And the MRI here showed was a midline frontal dysplasia. So it may also happen that you may see left-sided more preponderance. So don't get biased by the interictal lateralization in the midline frontal. If you localize to that area, you may be enough the semiology. So the same patient had intermittent runs of this theta delta occurring in the right frontal region. So this definitely gave us more clue towards the dysplasia and localization. Rhythmic frontal theta delta activity may occur. Then comes the dorsolateral frontal seizures. Now dorsolateral, this part is yield is definitely high of concordance of the epileptic zone, picking up on the EEG because 72% will show because it is close to the scalp electrodes, a smaller distance between the lateral cortex and scalp, and better orientation of the dipoles. Definitely sensitivity of interictal EEG is quite good in this, in the scalp EEG, but definitely intracranial is definitely better. In any frontal lobe, I think intracranial is always gives you better because now here you can see the, the referential montage. You see this FP2, F4, C4 showing a good spikes. The same, the whole right frontal lobe is a dysplastic in this patient. And the same thing is also seen in the, now these are the bipolar montage. You can see the whole right hemisphere is showing this intermittent spikes, sharp and multiple runs of epileptiform activities. And this is another patient, she also had a right frontal very clear dysplasia, and it showed runs of interictal this spike and wave discharges. And she was the one who would also present to us with a non-convulsive status, and where she will just be dazed and intermittently. So we operated her and she's doing pretty well after this. You may also see a single spike like this in interictally. Now let's go to the orbitofrontal features. Now here often abnormality detected by scalp EEG do not allow for topographic localization of foci residing in the basal frontal lobe, because you can understand inaccessibility of this basal frontal to the scalp electrode. So orbitofrontal is another area where we do not have a good localization value. When present, ID may have a regional distribution or appear generalized, or you have a bilateral synchrony. So sometimes they are propagated and can present over the central or frontal-lateral region. Sometimes may have a widespread, and you may see generalized discharges often. So now this one is showing this generalized discharges, and actually this was the gyrus rectus. I already showed you that patient, the video EEG. This was the basifrontal FCD, but it showed this thing. Now the same patient intermittently showed runs like this on the right side in the frontocentral region. So if you study the long-term EEG, you'll definitely pick up. It is also showing on the left side, but you can definitely see the preponderance is there on the right side. So you have to do a prolonged recording, and during sleep or during where you may find a localized discharges like this. So now let's go to the ictal EEG. Again, dorsolateral medial lobe. This is a very good paper where 127 seizures were evaluated, And it showed correct localization of epileptic zone in almost 65% of patients. 26% started with generalized EEG activity and 3% had false localization. The most frequent EEG patterns which they found was repetitive epileptiform activity in 36%, rhythmic delta in 26%, was EEG suppression in 14%, and rhythmic theta, which we see in temporal lobe in 9%. In a study, scalp electrode showed widespread seizure onset and MRI was normal or non-localizing, but subdural grid electrodes on frontal areas localized the seizure onset zone in almost more than 90%. So whenever you're suspecting, frontal lobe deep-seated lesion, always the subdural grid electrodes gives you better characterization. Now the mesial frontal area. So in this, absence of any ictal or immediate post-ictal slowing has been reported in this, frequently contaminated by movement artifact because it has a lot of hypermotor seizures, which we already saw. It may have an initial high amplitude slow wave transient or a midline sharp wave, and this may be followed by a low voltage fast activity or electrodecrement. One study reported paroxysmal fast activity in 33% and electrodecrement in 29% as an initial ictal pattern. The lateralizing information from ictal EEG is minimal. Localization, yes, only 25% had a localized or lateralized EEG and 75% had a non-lateralizing pattern in a study by Hamel and again. The depth electrodes usually placed bilaterally provides greater accuracy of lateralization and localization. And last comes the basal frontal. Now, the scalp EEG frequently does not help in localizing the basal frontal. As we all know, again, it is a base of the brain where the scalp EEG do not reach there. Ludwig et al. Demonstrated bilaterally synchronous epileptiform discharges with a bifrontal or frontopolar maximum with or without evidence of additional temporal lobe involvement. Chang and all showed that invasive sphenoidal electrodes and infraorbital scalp electrode definitely gave better. But even added to scalp in bisynchronous, they had a more basal distribution. False localizing pattern to anterior temporal region or frontal lateral region is also quite common in this. It may have a misleading widespread appearance. So you have to have semiology, MRI, PET, SPECT, everything studied together when you are localizing and lateralizing the ictal EEG. So the various types, if you see one, I've said there's repetitive spike and wave, paroxysmal fast activity, electrodecrement, bifrontal, bilateral frontocentral or theta slowing, and rhythmic delta. So this is one which you see that there is a decrement and then there is a fast activity which is there. Then later on as the movement starts, the EMG artifacts is coming up. Here again, the second is that you are having a right frontal rhythmic delta. It starts with theta and then goes over to the delta. Then here you are having a fast ictal rhythmic activity, which is again bilateral, generalized, and then it is followed by a spike and wave activity. And the most common which we find is that seizure starts and then there is all full of EMG and muscle artifacts. So in this, when you go further in this muscle movement artifact, you may see some areas where you may be able to find out some clues of ictal activity. So you have to, even though it looks like muscle movement artifact, you have to see each page carefully to find for any localizing ictal activity. So, Manjari, is there a time? Can I just show two cases?
Yes, there is time. Yes, please.
Yes. So I just want to share two operated case. This was a 34-year-old right-handed female. Seizure started since the age of 3 years. Frequency was pretty high, almost 10 to 1 in 10 days. And then whenever she started getting clustering. Then she developed a lot of behavioral abnormalities. Initially, when she came to us, we told her we tried managing the medically Almost for 2 years, we tried managing her medically. And then finally the mother said, either you operate her or you kill her. I just cannot manage her. So then this was her EEG, which showed this right side frontal and a temporal, right hemispheric discharges. And then as initially she was quite well controlled, having one seizure in 3 months, 6 months. And then by the time over 2 years, her seizure frequency increased. Then she started having almost every day. And that's when we decided, the brother who was intelligent enough, they said, agreed, yeah, ready for the surgery. So this was the interictal EEGs. And this was the ictal EEG. Now, ictal EEG again did not show us any localizing definite value. It showed a past activity like this. But this was a widespread frontal dysplasia cortex. And by the time she came to us later on, she was coming from some far off area. So she would come once in a year for follow-up. She started having a non-convulsive status, continuous epileptiform discharges in that area. So the PET CT showed like an ictal PET, and it showed the hyperdense area in this whole area. So then we decided to let her undergo surgery. She did develop hemiplegia because we operated this was the poster. This was the right hand she developed left hemiparesis. She has this weakness. We had already told her that pre-operatively that she will develop some weakness, but we had assured her that eventually she will recover. Now again, this right hand she is able to lift, left leg is weak. Now, definitely you feel what have we done? We have stopped seizure, but we have given her the hemiplegia. But let me tell you, we have not removed the motor cortex. So these patients are likely to. This is what her video is at the end of 3 months. She has no seizures. Her hemiplegia has recovered and she's doing pretty well. So do not get disheartened by the post-op hemiparesis, which we often see in frontal lobe seizures. And this is our post-ictal EEG. You can see the remarkable difference what has happened in now, our post-ictal EEG. Sunita Patel, her name was. So one more case. This was a 10-year-old male. First seizures started at the age of 3 months of age, and almost since 9.5 years he had. Initially, the seizures were infrequent as usual. They always have initially once in 6 months. But by the time he came to us, he had almost 12 to 15 seizures per day. Totally homebound, not going to school, and just on 5 anti-epileptic drugs, not controlled at all. And it showed this continuous epileptiform discharges in the right frontal. Red are coming from the right side. This was her interictal EEG. And this was the ictal EEG onset here. And then it showed a build-up in the right side here. And the spikes here. So further, and he also had a big right frontal dysplastic tonic frontal lobe. So we did the disconnection surgery. This was a CT, post-op CT on day 2. Obviously, this child also developed a hemiplegia. So this was the day 2. Right leg, hand is moving well. And you can see the left is hemiplegic. Now the same boy, he went to the native place and he did not want to come for follow-up. So the father said, I will send you the video how he's doing. So this was, now you can see that he has learned the finger nose test, which we used to make him do here. And now he walks. You can see the whole scar over his head. So within 28 days, he has recovered. And now at the end of 3 months, he has been going to school. The parents have kept a department photo in their temple, showing that you are God for us because my child is now going to school, is speaking now, is normal. So I think you have to decide that even if there is an hemiparesis, but there is uncontrolled seizures and it's really disabling the life, you must think of doing a surgery. Now there are 2 more quiz for you. It goes into a dystonic proceeding as a full body turn, which is quite typical of frontal lobe. You can see what the technician is talking. Shock lagana padega machine se. So you can see there is no pattern to his movement. He has topsy-turvy. And he continues like this for almost 3-4 minutes. So everything that shakes and is hypermotor is not a frontal lobe seizure. It is important to remember that. And in such patients, this one seizure you have recorded, you record another seizure after 2 hours. It will have a different semiology, different timings. And often it happens that you have the EEG showing a rhythmic discharges. Now I'll show you the another one. This was definitely a pseudo seizure. He continues to have. Now, another girl. See how rhythmic she is. Even the EEG will show a rhythmic discharges in this. Best is to such patients, give suggestion, precipitate a seizure. And now you can see now she has a side-to-side head movements. So they also get tired at the end. They don't respond. So these type of seizures, you have to remember that try and give a suggestion whenever you are in doubt. EEG is not showing anything, just showing a movement artifact. Just giving a suggestion by tuning fork may be enough. And also analyze each seizure with a different semiology. Often there might be a mixed seizures. So show the relatives whether these are a stereotyped habitual seizures. It often happens that they are here in the video EEG and that is the first time that starts showing a new type of seizures, which they'll say this was not there at the home. This may not be a habitual seizure. So it is important whenever you are analyzing and labeling as a pseudo seizure, confirm with the relative that these are the true habitual seizures which is getting at home. Then you label them as pseudo seizures. But he might be getting a different type of seizures, and the smart relative will always tell you कि नहीं ये अलग है और घर पे उसको अलग भी आता है. कभी-कभी ऐसा आता है, कभी-कभी different type. So it is important that you differentiate between the two with the help of a relative. Show them, and it is also important to show them when you're calling for follow-up, and you give them a seizure diary in that, ask them to mark true kitne hai, pseudo kitne hai. You have to tell them that these are from A type of seizure, these are B types of seizure, and they should mark how many of them they have got. And that's when you know whether your drugs are effective, whether you need to increase. If there are pseudo seizures, you need to have a psychologist and a psychiatrist on board, and not the anti-epileptic drugs which needs to increase. Thank you.
Hello.
Yeah, Manjari.
Yeah. Thanks. I think you showed nice.
I've finished well within time.
Yes. So we have time for questions, Sangeeta. So there's one slide which you showed of FERDA. So Dr. Balaji is asking, can we tell FERDA is abnormal?
Yes, see, FERDA, if it's occurring unilaterally in one of the area, definitely it is an abnormal. But if it is occurring bilaterally, synchronously, it may be due to a deep-seated lesion or it may be a normal variant also. So you have to interpret in context of the patient and whether it is asymmetric only on one side or whether it is bilateral symmetric.
Then Dr. Dr. Shravan is asking, can behavioral arrest be a feature of frontal lobe epilepsy?
Behavioral arrest is usually unlikely in frontal, but it can happen when they have a I have not shown that video. We had a girl who will go in a behavioral arrest and immediately go into a shampoo. So it can happen. But it is typically a temporal lobe where you have a prolonged behavioral arrest. But in a frontal lobe, the behavioral arrest is very short lasting. It's just a few seconds and then immediately it goes into a different hypermotor.
That is why sometimes they're called pseudo absences. They are so
Absolutely.
brief.
Frontal absences.
Frontal
sometimes.
absences or pseudo absences because they are so brief. So you can have behavioral arrest. There's another question: how to lateralize mesial frontal lobe? Mesial frontal lobe seizure, will there be lateralizing features always, or there may, how would you make out? So that is one of the questions.
So I said mesial frontal is difficult to lateralize, more easy to localize, but then you have to go by the EEG. You may have to go if there is elementary motor signs coming up if they are going for secondary generalization, whether you have a asymmetric posturing, or when you see an MRI which is localizing, but only on semiology, often it does because of the complex motor movement, fear. Lateralizing is difficult, localizing is more easy. Anything you want to add, Manjari?
Sometimes when it's like coming from the SMA or from the foot area,
posture, if you have things like that, then you can.
Then you may have a. Then. So there's one question, madam, you said that suggestions are giving for pseudo seizure. What are the kind of suggestions?
So by and large, what we use is just a tuning fork on the head, and we tell them that the vibrations are going into your brain. So this vibrations will bring about your seizures. We are not using anything apart from this, no saline, no spread, nothing of that. And we find this is the most simply and easily palatable by patient, because thus vibration does go into the head that time because you vibrate and put it on the head. And we have been using.
And you also have to keep on doing it repeatedly. So yes. Before you start the procedure, you tell them, now I'm going to put stimulating substance on your head, and that will produce some vibration, and you're likely to have a seizure, which is what we want to see. And during the process also, you keep doing it.
Yeah, you just don't do it once. The vibration stops, you start, do it again and put it again.
So you can't
keep on doing it.
Yeah. So some people think, okay, ek baar kar diya ho jayega. No, you have to keep doing it, because some of them have a low threshold, some of them
have a high threshold. Sometimes it happens that you have done in the morning, it was unsuccessful, but you do it in the evening, it becomes successful. But if you're strongly suspecting, you might have to do it twice, thrice also. So it is important. And also I've learned to tell them कि अभी vibration लगा रहो, ये machine सब seizure खींच लेगी. अभी you will not get any more seizures. Sometimes we give that positive suggestion also in there.
You should do a study, how
whether this acts.
So then can we get generalized discharges in frontal lobe epilepsy, and vice versa? Can we get frontal lobe discharges in generalized?
Absolutely, you can get focal discharges, are well known even in a JME, and the generalized discharges for the basifrontal, medial frontal, you'll get the generalized discharges. Both ways it is true.
So Dr. Shravan has asked, ictal cry. Where do we localize the ictal cry? Like
ictal crying by and large is for the temporal lobe, right temporal lobe more often. But sometimes a limbic and a cingulate gyrus may have those emotional component also.
So ictal crying is also known as diachroistic seizures.
Diachroistic seizure.
Yeah. And sometimes in hypothalamic hamartoma also you can get ictal crying.
Instead of laughing, they might cry.
Yeah. Then how do we differentiate hypermotor seizures coming from the premotor versus the prefrontal? So just premotor and prefrontal. How will we differentiate the hypocerebral?
So premotor area, often it is near the SMA. So you will have an elementary motor signs, of posturing. You may have a figure 4, or you may have a tonic asymmetric M2E signs. If you have those, they are likely to be a premotor. But if you have only stereotypies and a fear or things like that, it is more likely to be prefrontal.
So if you get more proximal, it's likely to be premotor. And if you get more distal, it's likely to be prefrontal. Then any particular drug you prefer in frontal lobe epilepsy, which Dr. Sutikshan has asked, Dr. Vasudeva, carbamazepine or levetiracetam or lacosamide, which one you prefer, which produces better control in your experience?
I prefer something with a generalized this thing, like, levetiracetam, valproate, and phenytoin, which has a generalized activity rather than a focal thing. I will prefer those in frontal lobe seizures. And let me tell you, whatever you use, but nocturnal frontal lobe seizures are always difficult to, control in spite of all the drugs. That happens.
So there's one question. Can we get somatosensory aura in a frontal lobe seizure?
Yes, I already showed that. You can get somatosensory auras.
That can, it may be a red flag. Sometimes you have to search whether there's a lesion posteriorly, but you can get it.
Almost one study showed almost 12% patients had somatosensory aura.
So many people, Sangeeta, have said it's an excellent talk. So congratulations. And the last part I'd like to say is that all that looks frontal may not be frontal, like you showed pseudo seizures. And also we know occipital lobe onsets can propagate to the front. So you can have a tonic, you can have a SMA posturing, you can have a asymmetric tonic posturing. In occipitoparital, propagating very fast to the frontal lobe, through the superior longitudinal fasciculus, through the inferior longitudinal fasciculus. You can also, have a, pseudo, like absence and a pseudo myoclonic presentation. So it may give a generalized. So frontal lobe epilepsy may look like a generalized epilepsy. So both ways it can happen. And you have to have a high index of suspicion. I think Dr. Sangeeta has done an excellent job showing us the EEGs and videos. And hopefully, you would have grasped that it's a very big globe. So, yeah. Thank you, Sangeeta. I think we're done with all the questions, and we look forward to you joining us as moderator again and again.
Next time.
Have a good night.
Bye.
Okay.
Bye. Thank you.
Bye-bye. Thank you so much. Thank you. And the Indian Epilepsy Society.
Yes.
That's my duty to say that. Okay, good night. Mr. Mohit?
Yes, ma'am.
हाँ, रिकॉर्डिंग भेज दीजिएगा.
Yes, no.
हाँ, क्योंकि वो बोल भी रहे हैं तो एंड में हम लोग डालेंगे वेबसाइट.
कोई इशू नहीं, मैं कल टुमारो भेज दूंगा.
Thank you.
Thank you.